Good evening, everyone. You're all coming into the room now, and welcome, welcome. It's lovely to have the community of practice all back together again for our first session together of 2026. And tonight we are in conversation with Una, and she is going to be talking to us about the cancer prevention and early diagnosis. So just to kick us off, just a few little domestics. As you will have noticed, the webinar is being recorded. So for that reason, we greatly appreciate if everyone can keep their microphones on mute. Your video can be on or off, whatever suits you best. But if you are experiencing any connectivity issues, it might be an idea just to turn your video off, and that might increase your reception. So if you do have any problems with sound or hearing Una when she's speaking, just check that your sound isn't muted or isn't turned down. And if you continue to have any issues, just log out of the call and then Grace will let you back in again. We do have the chat function live. So if you have any questions or any comments or any queries for Una, do please pop them in the chat and we'll come to them at the very end. We do do a little bit of anonymized information from the webinar, and there is a survey to complete. So we'd greatly appreciate if everyone would pop some commentary into the survey, and ideally maybe give us some ideas of things you would like webinar topics on. There may be other areas of cancer control and support you might like some information on, or other topics that might be of use to you. So this evening, we have not just Una Kennedy, who is the GP advisor for the National Cancer Control Programme, but we also have Aisling, and Aisling McLoughlin is the Chief 1 Pharmacist for the NCCP Cancer Drug Management Programme, and she's going to be popping in after Una and giving us a quick chat of some resources for us as pharmacists. So at this point, I'm going to pop over to Una and let her take the show over and give us all the information. So over to you, Una. Thank you so much.
Great. Thanks very much. Listen, thanks everyone for coming. It's a dark night and it's late and cold, and I'm sure everybody would prefer to be sitting on a sofa in front of a fire. So I do appreciate you being here, and thanks very much to IOP for having me here. So I am the GP advisor to the National Cancer Control Programme, and I'm just going to speak to you about cancer early diagnosis and prevention. So this is what I'm hoping to cover today. So it looks like a lot, but it's not as much as it looks. So just a very quick overview of cancer in Ireland, a quick rundown through some new stuff that might be of interest to you, more of a deep dive then into breast cancer, a quick chat about the non-specific signs of cancer, and then just a few resources at the end. So this is just the overview of cancer in Ireland at the moment, and these data are from the NCRI, the National Cancer Registry of Ireland. And really, if you ever want data around cancer or statistics around cancer, it's a great place to go. The stuff is really easy to read. You fly through it, and it's accurate and it's up to date. It's a great website. This is a headline number: 24,207 invasive cancers every year in Ireland. That doesn't vary much year on year. That works out then at 9,797 deaths per year in Ireland, which works out at approximately one person dying from cancer every hour of every day. Nowhere near as high as the number of cancers we actually have, but it's still a high enough number of deaths from cancer in this country. And these are the top causes of cancer death, like which cancers are causing all these cancer deaths. And I think this is going to come as a surprise. Now, I know this slide is a bit blurry, but I'll get back to it later. You can see here at the bottom, lung. Lung is the #1 cancer killer, and it kills 1 in 5 of our cancer deaths are accounted for by lung. And I think that'll come as a surprise to people. I think lung gets forgotten a little bit. Prostate is actually the 4th most common cancer killer, and breast is the 3rd most common cancer killer. So although those two are our most common cancers that happen, they're not the ones that kill most people in this country. And there is good news. 1 in 23 people in Ireland is a cancer survivor. A huge number of people are surviving cancers. We have over 217,000 people living with cancer in Ireland at the moment. And that amounts to a 50% increase in survival compared to a decade ago. So things are getting better, and things are getting better quickly in Ireland in cancer. Just to go down through the numbers, I might draw your attention to the far right of this screen, the grey chart here. This is males and females combined. And you can see prostate is the most common cancer in the country. But again, it's the 4th most common cause of cancer death. Breast is our 2nd commonest cancer and the most common in females. Lung and colorectal then are pretty much neck and neck for third and fourth. But as I said, lung is the most common cancer killer. And you can see there, lung makes up 10.6% of all cancers, but makes up 20% of all cancer deaths. So then, what's new in cancer in Ireland? And this is one that I think will be of interest to pharmacists. The bowel screen eligibility has been extended. So bowel screen started off 50 to 69. It's now 58 to 70. So everybody aged 58 to 70 is now eligible to participate in bowel screen. That's men and women. And the reason I put up the cancer deaths again there now is because we hear a lot about prostate cancer screening and why isn't there prostate cancer screening? And that's a discussion to be had perhaps. But it should be noted that colorectal cancer is as likely, if not more likely, to kill you if you're a man than prostate cancer. And actually, the uptake of bowel screen is kind of low amongst men. So there is a cancer screening program available to men. It's bowel screen. It's for a cancer that's just as lethal as prostate cancer, but the uptake isn't great. So we really need to push bowel screen, especially in men. So a brief rundown through the screening programs that we have in Ireland. So there are three: breast, cervical and bowel. And as you can see, breast and cervical are for females and bowel is for males and females. So breast is for all women aged 50 to 69. They get a mammogram every 2 years. And breast screening aims to detect breast cancer early, where your chances of survival are higher. It doesn't prevent breast cancer, it hopes to pick it up early. Cervical cancer is for females again, aged 25 to 65, every 3 to 5 years. And the aim of cervical cancer is to pick up pre-cancer cells. So it does not detect cancer. It is not designed to detect cancer. It is designed to detect pre-cancer cells. You remove the pre-cancer cells and they don't turn into cancer. So cervical check prevents cervical cancer. Bowel screen is quite unique. It prevents cancer and it also detects bowel cancer early. So what happens in bowel screen is you sign up for it. Bowel screen send you out a kit. You do the kit at home. You send it back to them. If the kit is positive, they'll invite you for a colonoscopy. On the colonoscopy, they may see nothing at all, of course, but they may see polyps. Now, most bowel cancers come from polyps. They're tiny little growths in the bowel. They're quite benign themselves, but they can develop into cancer. If they see the bowels, the polyps, they remove them. And obviously, if they're removed, they can't turn into cancer. So it can prevent bowel cancer. Other than that, when they do the colonoscopy, they could see cancer actually live in the bowel. Most cancers picked up on bowel screen are early stage. So bowel screen does both. It picks up cancer early and it also can prevent it. It's quite unique. This is what actually happens in bowel screen. Now, I expanded the photo here on this to try and make it as close to life size as possible. So this is actually what you get pretty much life size in the post when you sign up. They send this kit out to you. That little boo scoop, greeny scoop, I should say, you dip that into the stool, you dip it into the bowel motion. You don't have to stir it around or scoop out a whole load of poo, just a tiny little dip back into that plastic, clear plastic yellow container, package it up into the packaging and send it back to bowel screen. They send you a pair of gloves with it and they send you the packaging and it's free post. It's important if people get this kit, it's important to say to them that they have to leave it in the bathroom. So not on the hall table or in the kitchen cabinet because it never get used. It should be put in the bathroom and they should be encouraged to take it up as soon as possible before they forget. I know that there is going to be work coming for pharmacists to register people for bowel screen. I'm sure the screening service will want to talk to you about that themselves anyway. It may be that they have a separate portal for pharmacists to register people, but I know that this is how I register people. You go on to bowelscreen.ie, that little spot there, check the bowel screen register, and that'll lead you through it, and it's very straightforward. Now, some new resources. This is some new resources. I just thought I'd put them up here because they're new. This is stuff we did on penile cancer, and it's available on healthpromotion.ie. If you go on to healthpromotion.ie, click on cancer, you'll see a whole range of resources there. You can order them free of charge and they will send you hard copies free of charge. There's a little booklet, not a whole lot bigger than what you see there, and there's a little wallet card that's actually about the size of a credit card. And it's interesting, we got these done this year and they're, well, last year, I suppose, middle of 2025, and they're already out of stock. They've disappeared. There's a kind of an appetite for them. People want to know. It's not a common cancer, it's only about 80 cases a year. But the reason I'm mentioning it is because although it's not common, it is eminently preventable. About half of bowel cancers can be prevented through simple hygiene, and that's a wash. So in the shower every day, men and boys, draw back the foreskin, bit of a wash, and that's it. You don't need soap or anything like that, just plain old water will do. About half them will be prevented by that. The other half, approximately, can be prevented through the HPV vaccine. Um, so I'm just going to briefly mention the HPV vaccine. It's the vaccine for human papillomavirus. It's given to all first years in Ireland. Well, it's offered to them, and it protects you from the human papillomavirus. Um, I would be asked a lot about from parents. I mean, why are we vaccinating boys? I'm not going to vaccinate my son with HPV. Why would I do that? It's a girl's disease. It's only for girls that we're doing it. And that's not true. HPV, as you can see on the right side of the screen there, it accounts for about 3.7% of cancers in females, but so does account for some, a small number, 1.7% of cancers in males. The cancers that males get would be oropharyngeal, that's your mouth and pharynx, anorectal cancers, and penile cancers. Not many, but certainly some. And I think here on the left, this is really interesting. How many do you need to vaccinate to have an effect? If you go down to the end here, you would need to vaccinate 202 people to prevent one case of cancer. So if you imagine your average secondary school near me, where I live anyway, I think our secondary school takes in about 210 every year. So there's about one child every year in that school that was destined to get cancer, but won't now if they get the HPV vaccine. So I would just ask you, pharmacists are trusted and people do listen to you. You don't give this vaccine, I don't give it either. But if you're asked about it, please try and be positive about it. Another bit of news is that the lung cancer guideline for GPs is being updated. So this is a guideline that will list the sort of symptoms that we would ask GPs to keep an eye out for, and if people have these symptoms, to refer them to the lung clinic. Lung, I said, it's our third most common cancer, but it's our number one cause of cancer death. Vast majority of lung cancers are caused by smoking, a smaller number caused by radon. The early signs and symptoms of lung cancer can be non-specific. They can be vague and very difficult to spot. They tend to be older people. The median age of diagnosis is 70 to 74. They tend to be smokers. It's more common in people with COPD. So you may well see these people coming in and out repeatedly, getting antibiotics, getting steroids, looking for cough bottles, or you may even notice over time that somebody's just got a bit shook looking, as they say, where I come from. And if you see that, perhaps you'd consider, gosh, could this be something like lung cancer? That person really needs a chest x-ray. It can happen as well that as the pharmacist, you might actually be the only person who's seeing them all the time. If there's a practice where there may be 4 or 5 doctors, the person could be seeing a different doctor every time or could be seeing the nurse or whatever. The only commonality there might well be the pharmacist where they're going to for their prescriptions. So you might be the only person who's spotting that they're getting all these prescriptions and they're not getting any better. The guideline will be available on our website. It's well worth having a look at it. I think everybody should read these guidelines because people need to know the information that's in them. Now, the vast majority of lung cancers are caused by cigarette smoking. I'm sure at this time of the year, you have loads of people coming in wanting to quit smoking. And the good news is, I don't know if you might know this already, but everybody in Ireland, whether they have a medical card or not, everybody is now entitled to access the quit smoking service courtesy of the HSE. So they can come in to me, I can refer them up there, they will get free counselling, they'll get a prescription for their nicotine replacement, they can bring the prescription to yourselves and they'll get their nicotine replacement free of charge, just like on the medical card, and you'll get reimbursed for it. And that's everybody, whether you have a medical card or whether you don't have a medical card. Sometimes people don't like going to the counselling. They don't like the idea of being sent for counselling. They want to try it on their own. But if you try to quit cigarettes on your own, you're not as likely to be successful You have higher success rates where you get counseling with it, where you get a bit of support. So that's the updates. That's what's new at the moment in cancer. That's all the news I have for today. I'm just going to do a bit of a dive now into breast cancer, which is the commonest invasive cancer in females in Ireland, about 3,600 cases per year. And these are the breast cancer rates ticking upwards like so many things. The rates in males is fairly stable there. About 1% of breast cancers occur in males. Now, this is breast cancer survival. It's a very busy slide. I'm sorry about that, but I'll bring you over here to the red arrow where we look at 5-year survival. Now, 5-year survival is an interesting concept, I think. When I was a student, which was a long, long time ago, if you got to 5 years after a diagnosis of cancer, you were thought to be doing very well. Increasingly now, 5 years is not considered great anymore. Now everybody expects to live a lot longer with that. But 5 years has kind of become a convention and it's just widely used. I would say the same about the word survival. It sounds like somebody's barely hanging on, but we know that more and more people are surviving cancer and living with it and living well with it. Um, but anyway, if you're diagnosed with stage 1 breast cancer in Ireland, your 5-year survival, it's almost 100%. You're almost guaranteed the 5-year survival. And that's not so bad for stage 2, it's 93.4, but does fall off a bit as you get to a higher stage. So stage 4, it's just 36.9%. And I suppose that just emphasizes the importance of getting in quickly. If a woman finds a lump or a change in her breast, to get in really quickly. If she has a cancer, to get it diagnosed as quickly as possible when treatment is most effective. So who's getting breast cancer? And there's a fairly even spread here. Once you get over the age of 45, it's fairly evenly spread amongst the age brackets there. Really, it's like so many other cancers, it's more common in older people. Um, but it just should be said, it should be noted that there is that 13% of cancers that occur in the younger age group, and that's really important. It's really important to note that you're never too young to get breast cancer. You're never too young to get any cancer. And it's just very important never to dismiss a lump or a bump in the breast in a young woman, or indeed in a pregnant or breastfeeding woman. Now, so the risk factors, what might increase your risk of getting breast cancer? When we talk about risk factors for cancer, we divide them into kind of two brackets. The things you can't change, the non-modifiable risk factors, and the things you can't change, they'd be the modifiable ones. So non-modifiable would be the things you can't change. You can't change your age, that you're getting older. Can't change your family history. You can't say, I don't like my family, I want a new one. You're stuck with your family history. The modifiable things are the things you can change. You can change how much alcohol you consume, and you can change whether you exercise or not. So I'll go through the non-modifiable ones first, the things you can't change. So the things you can't change that can increase your risk of breast cancer. First of all, your age. It increases with increasing age, but just to stress, it can happen at any age, can happen if you're pregnant, can happen if you're breastfeeding. Your family history. This varies, and I think it varies because the data around it varies so much, but family history and genetics account for 10 to 25% of cases. Your reproductive history counts a little, so having children later in life or not having children at all can increase your risk. SES is your socioeconomic status. So most cancers are associated with deprivation and low socioeconomic status. Breast cancer bucks the trend here. Breast cancer is more common in affluent women. However, women who are deprived or from low socioeconomic status are more likely to be diagnosed late and have a higher risk of mortality. Next up is breast density. And this is something you might hear, breast density. Dense breasts are associated with an increased risk. I'll go through this a little more detail now. First of all, breast density, and you'll hear this. It pops up in newspapers and pops up on media. So what are dense breasts? Dense breast is a radiological term. It's what the breasts look like to a radiologist on a mammogram. And that's all it is. You can't tell if you have dense breasts by looking at them or by how they feel. It's purely based on the mammogram. Um, so if somebody is self-examining and says, "Oh, I think they feel very dense," no, that doesn't count. It's how they look on the mammogram. So, and a higher density of breast is associated with a higher risk of breast cancer. They're very common. About half of all women will have dense breasts. So then, if so many women have dense breasts and if we know it's a higher risk of cancer, why are we not doing anything about it? And the reason for that is because nobody quite knows what to do just yet about this. So in Ireland, our screening guidelines comes from the European Commission Initiative on Breast Cancer Guidelines Development Group. So it's a group that offers advice on this. And they don't recommend any additional tests in women with dense breasts. And that's because there's no real evidence to say what to do or what will actually lead to any improved outcomes. So there's no point saying, well, let's mammogram every year or every 6 months or MRI them every 6 months or every year. There's no evidence that any of that will make any difference. And if you're going to do it, you should at least have some hope that it'll make a difference. So there's more research and more data needed on this. So next up is the family history, another thing you can't modify, you can't change. So broadly divided into two groups here. So there's people, you see on the right, the genetic risk, 5 to 10% of cases of breast cancer are down to a genetic risk where people have a known gene. There's a further 10% then that are down to a family history. So you might have a family of 6 sisters and they all have a particular gene and they have a high risk of breast cancer. That's the genetic risk. You might have a family of 6 sisters where several have developed breast cancer, but nobody has found a gene in them. And that just means they haven't found a gene, but they do have a family history, clearly. There's quite a number of genes here that contribute to your breast family history. There's loads of them, and there's new ones being discovered all the time. The commonest would be the BRCA genes, BRCA1 and BRCA2. And I suppose, what do you do? Somebody, and it does happen, somebody arrives in and says, I'm onto my sister in Australia. She's had a blood test done. She's BRCA positive. She has the gene. What do I do? Or you might have someone come in who's just back from Australia, back from the UK. I've had this genetic test. I'm BRCA positive. What do I do? The answer is in to see their GP, and I'll send them up to the local breast clinic for follow-up for surveillance. What you don't do is start organising your own ad hoc surveillance where you're getting your own mammograms or your own MRIs every so often. Go and get it done properly, set up by your local breast clinic. They'll sort it out. So other risk factors then, moving on to the modifiable risk factors, the things you can change that increase your risk of breast cancer. So there's a bunch of them. So they reckon about 20% of breast cancers are due to things that you can change. Not a high percentage, but a substantial enough number there, 650 per year in Ireland. In no particular order, I've put alcohol consumption first. About 7.5% of breast cancers are thought to be down to alcohol. So it's not a huge percentage, but it works out as a significant enough number of breast cancers every year. And it's just important to know this. Every alcoholic drink you have is doing you harm. In Ireland, there are alcohol consumption guidelines, but it's important to know that they are low risk guidelines. They're not no risk guidelines. There is no safe level of alcohol that you can consume. Every alcoholic drink is harming you. The more you drink, the more harm it'll do. And that applies to everybody. That thing that you hear out there about how a small amount of alcohol protects you from cardiovascular disease, that's not true. Next up is overweight and obesity. Being overweight is a risk factor in premenopausal women, is associated with decreased risk in premenopausal women, increased risk in postmenopausal women. Breastfeeding can reduce your risk. So for every 12 months you breastfeed, you reduce your risk, they reckon, by about 4%. Some medications can increase your risk, such as HRT and the contraceptive pill. Physical activity, the good news, physical activity can decrease your risk of breast cancer. And for all sorts of reasons, not just breast cancer, we're all advised to get 2.5 to 5 hours of moderate intensity aerobic activity, or at least 1 hour and 15 minutes to 2.5 hours of vigorous activity every week. Any amount of physical activity will help, anything at all. Now, talk about HRT and breast cancer. I know you've done a module on HRT, but I'll just run down through this. HRT. So when a female goes through the menopause, they stop producing the female hormones, estrogen and progesterone. And HRT replaces those hormones. So that's what it's, hormone replacement therapy. Two broad types of it. There's estrogen only, and then there's combined estrogen and progesterone, where they're combined together. Estrogen only you give to women who do not have a womb, and the combined HRT is for everybody else. So what happens with HRT and breast cancer? So I divided people up into two broad groups, the women who have a breast cancer history and everybody else. So if you've had breast cancer, usually you'll be advised not to take HRT. If you have a family history of breast cancer, that's a bit complicated. I refer those women to the complex menopause clinic. They do need individual assessment, and it kind of depends on the strength of the family history and whether or not they have a positive genetic test. If there's no history at all and you want to go on HRT, that's fine. Breast cancer risk increases with combined HRT, and most women are on that because most women haven't had a hysterectomy. The actual increase is very low. So for every 1,000 women who take HRT for 5 years, you'd see 4 or 5 extra cases of breast cancer. So it's very low. The risk increases the longer you take it, but it falls again after you stop taking it. So a slight increase in risk, there's no point pretending that there isn't. It's not a huge increase, and it falls again once you come off it. There's a lovely representation here. And again, this is from the British Menopause Society. It's for UK women, women in the United Kingdom, but they'd be broadly similar to the Irish population. And this is how they present it. It's very, very nicely done, I think. So if you take 1,000 women aged 50 to 59 years, approximately how many of those women will develop breast cancer over the next 5 years? So you take those 1,000 women, aged 50 to 59, over the next 5 years, we know that 23 of them will get breast cancer. That's just what will happen. If you do nothing with them, they're just out and about, 23 will get breast cancer. If you put those 1,000 women on HRT, we know that over the next 5 years, approximately 4, they're saying 4 here or 5, will get breast cancer. So that's the difference that HRT will make to that group of women. This is if you take those women and they all start drinking alcohol. So you have that 1,000 women aged 50 to 59, they all take 2 or more drinks a night. Just 2 or more. I think a lot of people do that. If that happens, 5 extra cases of breast cancer will happen. That puts it into context with alcohol consumption. If you take those 1,000 women and they're all overweight or obese, how many will get cancer over the next 5 years? An extra 24. It'll double the number of cases of breast cancer. However, if you take those 1,000 women and they all take up exercise, you'll have 7 fewer cases of breast cancer. And what's interesting with the exercise is that's unrelated to weight. Even if you never lose an ounce of weight with the exercise, exercise in and of itself reduces your risk of breast cancer. So just breast cancer as cosmetic implants. I don't know whether you guys get asked these things, but I have certainly been in pharmacies and heard people ask the most extraordinary things of their pharmacist. So maybe you'll get asked this. But breast implants, what impact do they have on breast cancer? So breast implants can be used for breast enlargement or enhancement for cosmetic reasons. They can be used post-mastectomy. They can be used to correct congenital deformities or anomalies, and they can be used for transition surgery from male to female. Do they cause breast cancer? And the short answer is no, not the common types, not the usual stuff. It's been well studied. There's no association, or at least no association has been found, except one, this one here, anaplastic large cell lymphoma of the breast. So there was one type of breast implant that was taken off the market in 2018, and it was associated with this type of lymphoma. It's very, very rare, not at all common. And we shouldn't be seeing it much, if at all, anymore. But if someone develops a sudden swelling in the breasts and they've had this particular type of implant, they should get seen to. The only way you'll know if you have this implant is if you go back to the person who put them in. But they've been off the market since 2018. So what should women with breast implants do? Nothing different to anybody else, really. Follow the screening guidelines like everybody else. Be breast aware, which is to say they should be examining their breasts themselves just like everybody else. They should let their healthcare professional know. So if you're having a breast examination, they should let people know. And when they're going for screening, let people know that they have a breast implant. So back to breast screening. So we were at this already. So breast is for women aged 50 to 69. It's a mammogram every 2 years. It does not prevent breast cancer. It is just aiming to find breast cancer early. And what actually happens at breast screening? So this is like the significance of these photos. It's just to let women know and not to be put off from breast screening. You are given a little cubicle on your own. It is very, very private. You really are all on your own. There aren't crowds of people floating around. The advice to women is to kind of dress for the occasion. So wear a top and a bottom. So you can just slip the top off over your head and you don't have to fully undress, and you can slip it back on over your head then when you're done. Mostly they try, if not always, to make the radiographers female. And that's the machine. So you stand up against the machine. The breast is kind of put on this. It's actually kind of plastic, but it looks metal there, but it really is kind of plastic. And another plastic thing is pushed down on it just to try and flatten the breast. And the radiographer then may move you or adjust your position slightly. It might take a couple of goes to get the proper image. It doesn't mean they've seen anything or that they've found anything. It just can take a bit of just shuffling around or wiggling around to get you into the right spot. That's all. It's over in a few minutes and you get your results in the post a few weeks later. On average, and these are the breast check data, on average, out of every 1,000 women they screen, 7 will be picked up with cancer. The remaining 993 will get a normal result. Of those, there will be 2 women who will ultimately have a cancer that's not picked up. Now, whether it was there on the day or whether it popped up very shortly afterwards, it's very hard to say. But of the 993 who get a normal result, there will be 2 that will have a cancer that is not detected. Now, to move on, breast cancer, that's the screening, and those are the risk factors. What are you looking for, or what are you hoping not to find, I suppose, in terms of breast cancer? And this is the breast cancer GP referral guideline. This lists the symptoms that we as GPs are asked to look out for. And if people have these symptoms, we're encouraged then to refer them onto the breast clinic. You can find it on our website there, hse.ie/cancer. And it's the sort of document that, again, everybody should nearly read. And it is a very quick, easy read. It's just a few pages. It's an easy read document. And we divide it into a few bits. We divide it into the breast itself, we divide it into the skin, and we divide it into the nipple. So in the breast itself, what are you looking for? You're looking for, first of all, a lump, be it in the breast or in the armpit. Remember, the tail of the breast can extend up under the arm. So when women are examining their breasts, they should check up under the arms as well. And it's not just lumpiness. Even if it feels lumpy, as opposed to finding a definite lump, that's enough to say you should be probably getting it checked out. Or if you find that the breasts have changed in size or shape or the texture, or there's little nodularity there, get it checked out. Changes to the nipple, then you may have blood coming from the nipple or serous fluid, which is watery, yellowy fluid coming from the nipple. You might find that the nipple is pushed back into the breast and you can't get it out again. It's stuck in. And then the skin changes. So there's a few changes that can happen on the skin. First, there is redness of the skin, and that's an abscess under the skin, and that should go to the breast clinic. Puckering or dimpling in the skin, that's a thing called peau d'orange, the skin of the orange. It's where the skin gets thickened and dimpled like an orange skin. And then finally here on your right, we have nipple eczema, eczema on the nipple that doesn't respond to treatment. And again, it's just important to say, you need to watch out for the pregnant women in these situations and in the breastfeeding women. And I think particularly the redness of the skin. Certainly, yeah, breastfeeding women can get mastitis, and that just gets treated with antibiotics, that resolves. But everything that happens to pregnant women or breastfeeding women isn't necessarily down to pregnancy or breastfeeding. And we've all had cases where we've had women who are pregnant or breastfeeding who've turned out to have breast cancer. And it's just too easy to put everything down to pregnancy or breastfeeding. Um, you just need to be cautious and careful when it comes to certain groups of people. So what happens next? So when someone comes into me with a breast lump, um, they get referred pretty much straight away. And there are 8 breast centres around Ireland. There's 4 in Dublin and there's 4 outside Dublin. So in Dublin, we have James's Mater, Vincent's Beaumont. Outside Dublin, we have Cork, Galway, Limerick, and Waterford. And if I send somebody up to the breast clinic, they will triage them. If they're triaged as urgent, they'll generally be seen in a couple of weeks. So they're seen very quickly. So you don't end up waiting forever. Just by the by, these clinics are there for lung and for prostate as well. So if somebody has lung cancer symptoms, or if somebody has signs on a chest x-ray suggestive of lung cancer, they can get referred up to any of these 8 clinics, 4 in Dublin, 4 outside Dublin, and they will be seen within 2 weeks, usually 10 working days. Same for prostate, 4 in Dublin, 4 outside Dublin. Prostate, the waiting time is a bit longer. I think it's 4 weeks off the top of my head. So I'm just looking at, thought I'd put up what I think is good news, really. I beg your pardon. Breast cancer survival overall. Um, this is slightly different to the slide I showed earlier because it looks at 10-year survival. Um, Now, problem with it is that if you go down to the bottom of this chart here, you will see these numbers come from 2014 to 2018. So, they're already approaching 12 years old. So these are old numbers. The other point about these numbers is that they apply to all cases of breast cancer, whatever stage you were picked up at, early stage and late stage. But even so, the average 10-year survival is 77%, just over 3/4 of people surviving for 10 years. And you can be sure that those data are better now than they were 12 years ago when these numbers were collected. And you can be sure that for the early stage breast cancers, they're better again. So there's a lot of hope out there, but it's really important to get people in ASAP if they have symptoms. So I wanted to talk about some of the vague symptoms of cancer. Um, because I suspect that people will pitch up in front of their local pharmacist with some of these symptoms. So I wanted to let you know about them. We know that up to 50% of people with cancer will present with vague symptoms, with symptoms that won't tell you or indicate to you that even there is a cancer there or what sort of cancer somebody might have. And these are the sort of vague symptoms that we're all supposed to look out for. So the first is weight loss. Anybody with new and unexplained weight loss, just 5% in 3 months, or a strong suspicion. If they haven't weighed themselves, but you're looking at them and you know they've lost a ton of weight or the clothes have got loose in them, that's a concern. 5% is not a massive amount of weight, but we all know how difficult it is to lose weight. So if you see somebody and they're just getting smaller and smaller and smaller and there's no good explanation for them, that's a red flag. Constitutional symptoms, so loss of appetite. So somebody's coming in, I don't know, looking for Ensures, or they may be saying they want vitamins or something to pick up the appetite. Fatigue, and fatigue is an interesting one. I'm sure everybody in this call is exhausted, but it's people who have cancer will often say to you, I knew it. I was absolutely exhausted. I knew there was something wrong. Nausea, malaise, just feeling generally unwell, bloating. And when we say bloating, we mean bloating that doesn't go away. So, sometimes after a heavy meal, yes, the tummy can feel a bit bloating, but then it goes away. Bloating that doesn't go away needs to be checked out. Abdominal pain, so new, unexplained, vague abdominal pain of 4 weeks or more, or less if you're concerned about them for some reason. It could be almost anything, but if it's going on and on and on, it needs to get checked out. And the next one is pain generally. So new, unexplained, unexpected, or progressive pain, including bone pain of 4 weeks or more. So if somebody bumps their shoulder or is in a car crash or something, and yes, you expect them to be in pain. So there's a good explanation. And you don't expect that pain to progress. You expect it to get better and better and better as time goes on. But somebody has pain that they can't explain. They can't understand where it came from, and it's getting worse and worse and worse. That really needs to get checked out. And finally, I've put this in at the end, GP gut instinct. There's a lot of evidence in the literature around GP's gut instinct. So if a GP looks at you and goes, God, I have a feeling there's something wrong here, that actually is a red flag. Now, I've not found anything similar for practice nurses. I've not found anything similar for pharmacists. But I have a strong suspicion that if, as a pharmacist, you know someone a long while, you're used to people coming in and out, you're used to seeing them, you're used to listening to them and talking to them, I would bet that the pharmacist's gut instinct carries a bit of power as well. So I would say to you, if your gut instinct is telling you there's something amiss, you could very well be right. So then I'll just run down through some resources. There's loads of stuff. These are all on healthpromotion.ie. Just because we were talking about breast cancer, I said I'd mention cancer. Click cancer there and then search for breast and you'll find a load of things here. This middle one is an interesting one. It's a hanger that you can hang over a door handle or hang in a shower or a changing room or something. And that proved very popular. It went out of stock very quickly. I think we're having to restock it. But they can all be sent to you free of charge if you just go into healthpromotion.ie. Other resources, we have an early diagnosis of cancer e-learning program. It's available on hseland.ie. There's 2 modules in it, each is half an hour long, and they're acceptable for 1 ICGP external CME point. We have another one on reducing your cancer risk. That's more in depth about the steps you can take to reduce your cancer risk. That's also on HSE Land. There's 11 modules there. They're about 10 minutes long each, and they also qualify for CPD for the ICGP. So I think they're transferable across to yourselves, I think anyway. So then just in summary, please, please, please remember bowel screen. Encourage it everywhere you can. It's the only screening program that's available to men in Ireland. Please, if anybody is talking to you about the cervical cancer vaccine, please be positive about it and be positive when it comes to parents of boys. Boys do benefit from the vaccine. Please encourage quit.ie. Even for somebody who doesn't want to go for counselling, just it's worth saying it to them, look, your chances of quitting are higher if you do engage with quit.ie. It's important to promote breast awareness as much as we possibly can. Watch out for the non-specific signs of cancer also. And then finally, the resources are available on healthpromotion.ie. So one last thing is our World Cancer Day webinar. So these are very popular. They're always great webinars. It's on Wednesday, the 4th of February this year, which is World Cancer Day 2026, from 12 p.m. to about 1:15. You can register for it by going on to hse.ie/cancer prevention, and you'll find the link and that'll register you for it. And the topic this year is small steps, big impact, and it's about physical activity for cancer risk reduction, the benefits of physical activity. And that's me. Thank you. I will hand you over to Aisling McLoughlin, who's our Chief 1 pharmacist at the NCCP, and she's just going to share some resources with you as well. So thanks very much, everyone. Thanks, Aisling. I'll stop sharing now.
Great, thank you. So I know we're close to time, so this will only take a minute, but I just wanted to take this opportunity to highlight 2 resources that we have and that are freely available online and may support you in caring for cancer patients. So firstly, the NCCP National SAP regimens are a great resource, and at least we think so anyway, but we developed the regimens to support safe and evidence-based, cost-effective cancer treatment for all Irish cancer patients. So these regimens are developed under, I suppose, a robust governance framework and under the guidance of medical consultants involved in the treatments of patients with cancer, with input from nursing, pharmacy and other healthcare professionals. They're a key enabler of quality treatment of patients with SACT, and they underpin the National Cancer Information System, which we know as NCCP. So they're all there. They're split out into different landing pages depending on tumour groups and types, and a lot of them are there for the oral anti-cancer medicines, which are helpful for community pharmacists, I suppose. So then the next resource, whoops, sorry, which some of you may have already become aware of, is the IAOP Cancer Care Hub. So the NCCP were delighted to collaborate with the IAOP to develop this hub, which is intended to be a good resource for all pharmacists, and we're hoping that it's especially useful for community pharmacists. I suppose we know that the role of the pharmacist is expanding, and in particular community pharmacists, due to the increasing number of patients on SACT, and then also the number of patients on oral anti-cancer medicines. I suppose we also know from various bits of research that community pharmacists have welcomed increased educational support on the topic of cancer. So I guess with all of that in mind, this hub has been designed to be an easily accessible single location where pharmacists can find information, resources relating to cancer care, and the content within the hub. Then it has been organized into 6 main pillars. You can see that there on the right hand side of the screen. They're kind of color coded there. And they reflect the cancer care continuum. So that's from prevention and detection right through to treatment, management of side effects, and then to palliative care and survivorship. Within each pillar, there's resources have been organized into 3 categories. So there's pharmacist information or immediate information, and this is kind of information types that are handy when you're on the go. You've lots going on. Then there's kind of pharmacist further information for when you've a bit more time. These would include things like webinars and take a bit longer. And then there's also some good information there for patients, so that you can direct patients to the right resources. So that was it from me, and thanks, Una, for giving me those couple of minutes. And if anyone has any questions or feedback in relation to any of those resources, we very much welcome them. So thanks very much.
Thank you both for that information. That was super. So if anyone has any questions, please pop them in the chat now, or feel free to turn on your mic and chat directly with Una or Aisling. As Aisling mentioned, there are some wonderful resources in the IOP web pages for us. So there was a webinar in HRT previously, if anyone has any questions in that space, and in NRT as well as the Cancer Care Hub, which is there. Una is kindly going to put a document together for us after, where she'll pop all her resources up so we can access them there, and you'll be able to access them with the link for the webinar afterwards as well. There was one question there, just Una, relating to the topic of dense breasts. Asking the question, do you need an MRI for that, or is the imaging for the mammogram sufficient?
No, the mammogram's fine. It's not so much that the imaging isn't great on mammogram. It's just a reference to their appearance on the mammogram. So the mammogram does fine. But at any rate, as I said, there's just no evidence to support any other means of screening or surveilling these people just yet. Nobody knows just yet. I dare say it'll come in due course.
Okay, super. And then for guiding our patients for the bowel cancer screening, you'll pop the resources for that
Yes,
up
sorry,
for
I thought
us
I'd
as well.
send them. I'll send them on. Yeah, I thought I'd sent them already, but I will. Yeah.
And are they free, the mammograms and the bowel screening?
Yeah, the screening colonoscopies are free. The best mammograms under breast check are free, which is great. And the colonoscopy is an interesting one. Like I would often hear people say, "Oh, I'm not going for bowel screen. I'm not having a colonoscopy." But like for a start, step 1 is not a colonoscopy. Step 1 is just the test you do at home. And after that, you get invited for the colonoscopy. You're not made to go for it. You're invited to go for it. But yes, it's free. Yeah. And it's not as bad as people think. They fear terrible things.
And thanks for showing us what was actually involved in the bowel screen, because it's good to know. It's one of those things, if you haven't done it yourself, you're not exactly sure exactly what it is. So at least we've seen that now. We can say it's a very non-invasive.
It really is. It's not that bad. But I think people think they're just having to kind of climb into the toilet nearly, and but it's not. It's just a very simple dip. Yeah.
That's good. That's good to know. And just another question there on the dense breast. Is that something that continues after the menopause, or will the denseness of the breast reduce post-menopause?
As far as I know, it is. It's the way you're made. It's the way you're made.
You are how you are.
Yeah, you are how you are. Yeah.
Okay, that's good to know. And about half of the population have dense breasts and half don't. So there's just that slightly greater increase with the people with dense breasts. Okay, that's good to know. So nobody will know until they get the actual mammogram.
You have a mammogram, you don't know. Yeah.
Yeah, and then would they let you know that at the mammogram,
They
or
do. They have started reporting on it. But again, like part of the problem with even reporting on it is that nobody quite knows what to do. Well, nobody knows at all what to do, but they have started reporting on it now. And I suppose that's a start, is kind of logging it. And then when it's decided what you do, at least you know who those people are. So,
yes,
um,
okay.
but as I say, as yet, the best we have is the mammogram with breast check. That's the best
Okay.
screening we have.
So it's really just a you are or you aren't, and there's nothing
Yes,
more
yes.
there's
No,
nothing more
not
to
really.
take
No,
from it
no,
than that.
no.
Super brilliant. Okay, well, there's no more questions coming through. So I'll thank everyone for dialing in. I will just flag to all that the survey is there if you would take a few moments just to complete it. And if there's any topics you would like the IOP to cover in the future, or any specific area of cancer you'd like us to cover, please let the IOP know, and they'll go and organise that on behalf of the profession. Next, I will just let you remind you this is a good opportunity to start your next CPD cycle. So if you're on your laptop now, you could just start it, and you can always finish it later when you have a chance to look over Una's resources and get your next CPD cycle ready to go. And then in preparation for our next webinar, which will be in 2 weeks' time, again at 8 o'clock, this time, the IOP are going to be sharing and in conversation with the IPU, and we're really going to be getting into the nitty-gritty of the common conditions and what establishing a service in your pharmacy is going to look like. So that will be an interesting one for those in community practice to look at. So with that, my thanks again to Una and to Aisling for the wonderful information they've shared with us tonight. And we look forward to seeing you all again in 2 weeks on the 28th of January. So thank you all, and have a lovely evening.